Good afternoon. As a land-grant institution, we would first like to acknowledge the Tongva peoples as the traditional land caretakers of Tovaangar, that is the Los Angeles Basin and South Channel Islands. Welcome to the 2021 Health Policy Seminar Series at the UCLA Center for Health Policy Research. Before I introduce today's webinar and speakers, I would like to introduce myself. My name is Karina Mushro. I'm an associate professor of health policy and management at the UCLA Fielding School of Public Health and the new associate director here at the center after having served as a faculty associate for the past 5 years. I'm grateful to be able to help expand the center's reach in global public health research. Thank you all for joining us for today's webinar, Who is Caring and How Are They Faring? A look at family and friend caregivers in California. An estimated 6.7 million people were caregivers in California in 2020. In a study released earlier this week, UCLA CHPR researchers found that a substantial proportion of family and friend caregivers in California are struggling financially, physically, and mentally. Today's webinar features data from the center's 2020 California Health Interview Survey, or CHIS, which is the first set of data on caregivers in over a decade. In the study, authors identified which caregivers across different demographic backgrounds were struggling most and found that the severity also varied based on factors such as the amount of time spent caregiving per week. Researchers also discovered that caregivers were given little, if any, financial support for their responsibilities. Our presenters today are the lead authors of this newly published study: Sean Tan, Senior Public Administration Analyst, and Dr. Kathryn Kietzman, Director of the Center's Health Equity Program and Senior Research Scientist, as well as Associate Researcher at the UCLA Fielding School of Public Health. In addition to providing details about California's caregiver profile, they will also discuss several proposed policies and assembly bills, which, if passed into law, could expand the state's Paid Family Leave Act and provide sufficient income replacement and job protection. The presentation aims to provide an understanding on how various stakeholders can respond to caregivers' financial, physical, and mental health needs and may be used to support nationwide policies. As always, if you would like a PDF copy of today's presentation, please email the Communications Department at healthpolicy@ucla.edu. The webinar is being recorded and will be available on our YouTube channel in the coming weeks. Before we begin the presentation, I'd like to share an upcoming event. On Thursday, December 9th, our CHIS team will be holding a data user training to demonstrate how to use CHIS's free online data tools to get data on a wide range of health topics across many socio-demographic factors. The 90-minute training will cover various tools and dashboards, including Ask CHIS, Ask CHIS Neighborhood Edition, and the CHIS 2021 Preliminary COVID-19 Estimates Dashboard, which has provided timely data on COVID-19, including risk reduction behaviors and personal and financial impacts of the pandemic. A link to register for the data user training will be posted in our chat. Again, thank you for joining us today. Let's begin today's discussion with Sean Tan.
Thank you so much. And thank you, everybody. Good afternoon, and thank you for joining us today. My name is Sean Tan, and I am joined by my colleague, Dr. Kathryn Kietzman. Today, we will be presenting on our findings regarding family and friend caregivers in California. First and foremost, we would like to acknowledge and thank Archstone Foundation for supporting this policy brief. This is the first time in a decade that CHIS data on caregiving has been analyzed and presented in a policy brief format. We are very grateful for Archstone Foundation's support on this matter. The contents of this presentation and policy brief does not necessarily represent the views of the funder and are solely the responsibility of the authors. In this presentation, we will discuss the status of family and friend caregivers in California and highlight some of the major issues facing caregivers in terms of their health and well-being. We use data from the 2020 California Health Interview Survey to develop our findings. We will also talk about policy recommendations to mitigate the negative health outcomes, close the gaps in terms of health disparities, and address health inequities facing family and friend caregivers that we have identified in the policy brief. The policy brief and its accompanying documents, including the appendix and infographics, are available on the UCLA CHPR website. Before we go over our findings, I would like to talk about what we know about caregiving. For one, we know that the nature and intensity of caregiving fall along a broad continuum. What I mean is that family and friend caregivers perform a variety of tasks and services, such as providing emotional support, assistance with household tasks and personal care, providing health and medical care at home, navigating complicated and fragmented healthcare systems, as well as long-term support services systems, and serving as surrogate decision makers for their care recipients. There are also challenges and rewards associated with caregiving. In terms of challenges, studies have shown that caregiving is associated with decreased use of preventive health services, as well as increased risk for negative physical or mental health outcomes. Due to their caregiving responsibilities, caregivers also miss opportunities such as educational or career advancement. But also, caregiving has its rewards. For one, caregiving is seen as a way to give back to a family member or friend who has taken care of them in the past. Family and friend caregivers are the backbone of the long-term care system, but have been largely ignored in policymaking. Caregivers often do not identify with being called a family caregiver. Rather, they associate with the act of caregiving, which they view as a familial responsibility, or as previously mentioned, a way to give back. Policymakers often see caregiving as an informal work or not part of the workforce, and therefore ignore or overlook the contributions of caregivers to our long-term care system and in our society. Despite the contributions of caregivers being rather invisible, the degree to which it affects us all is great. As First Lady Rosalind Carter once said, there are 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. While National Family Caregivers Month ended last month, I hope that we can continue to celebrate caregivers and pay attention to their needs and take bold steps to address the issues affecting caregivers all year round. So let's talk about who are the caregivers in California. In this brief, we define a caregiver as an individual who provided care to a family member or friend with a serious or chronic illness or disability in the past year. Using data from the 2020 California Health Interview Survey, we found that 6.7 million adults in California identified as being a caregiver, and nearly 3 in 5 caregivers were women. Caregivers in the state nearly represent every adult age group. Nearly 3 in 5 were about 45 years of age or older, or those who are at the age nearing retirement. 1 in 5, or 20%, are older adults, or adults ages 65 and older. Nearly 4 in 5 were white or Latinx. Additionally, 11% are Asian, 6.3% are Black or African American, 0.5% are Native Hawaiian or Pacific Islander, and 0.7% are American Indian or Alaskan Native, and 3.4% identify as 2 or more races. Who do they provide care to? In 2020, 2/3 provided care to older adults 65 years and older, with 1 in 5 providing care to those among the oldest old, or individuals ages 85 and above. 1 in 5 reported providing care to someone with Alzheimer's disease, dementia, confusion, or forgetfulness. And a majority provided care to someone who did not live with them. Caregivers increasingly care for much older individuals who are more prone to frailty, at a higher risk for falls, and more likely to develop Alzheimer's disease or other dementias, all of which intensify the demands of caregiving. While caregiving is essential, there are hidden costs associated with caregiving. Now we'll talk about the opportunities costs for caregiving. What we found in our study is that half of caregivers reported providing 1 to 5 hours of care during a typical week. 1/4 provided 6 to 19 hours of care. and 1 in 8 provided 30 or more hours of care during a typical week. In terms of working hours, 9.7% of caregivers reported working a part-time job, which is equivalent to about 1 to 20 hours of work per week, and 53.4%, or over half, reported working a full-time job. As mentioned earlier, due to the caregiving responsibilities, caregivers face a stiff trade-off, such as missed opportunities for educational or career advancement, but as well as less time spent caring for themselves and for their social needs. In our study, we found that more than 9 in 10 caregivers received no payment for providing care. On top of being uncompensated for their work, many caregivers assume out-of-pocket costs for care-related household and healthcare expenses, estimated at around $7,200 per year nationally. In 2017, the value of unpaid contributions was about $470 billion in the United States and $63 billion in California. With greater demand for caregiving in 2020, the value of these contributions have only increased. So now let's talk about financial stress due to caregiving. We found a positive association between the number of hours providing care and financial stress. Financial stress in this infographic represent caregivers who felt somewhat or extremely financially stressed. About 13.4% of caregivers who provided 1 to 5 hours of care in a typical week felt somewhat or extremely stressed financially in the past year due to their caregiving responsibilities. And again, this group is over half of our caregiving sample. The proportion of caregivers who felt somewhat or extremely stressed financially almost tripled among caregivers who provided 20 to 29 hours and 30 or more hours of caregiving. And these differences are statistically significant when compared to those who provided 1 to 5 hours of care. Increases in financial stress associated with greater caregiving hours represent the opportunity costs that family caregivers face. As caregivers spend more time providing care, they have less time during the week to take on a full-time job or a part-time job or an income earning opportunity or an opportunity for career advancement. We also looked at financial stress across racial or ethnic categories. The proportion of Black or African-American caregivers who reported being somewhat or extremely financially stressed was greatest at 28% when compared to all racial or ethnic groups. American Indian, and Alaska Native and Native Hawaiian and Pacific Islander are not shown in the infographic due to statistical unstable estimates, but they are available in our policy brief. About 21.9% of Black or African Americans, 15.3% of Latinx, and 17.6% of Asian caregivers reported being somewhat stressed financially. These percentages are also statistically significant when compared to white caregivers at 12.1%. The hidden cost of caregiving goes beyond monetary value. As mentioned previously, caregivers are at increased risk of negative or physical or mental health outcomes. In this graphic, we found in our policy brief, 1 in 7 caregivers reported a physical or mental health problem in the past year due to their caregiving responsibilities. Similar to financial stress, we found that increases in the number of care hours provided in a typical week was associated with increases in the proportion of caregivers who reported experiencing a physical or mental health problem due to caregiving. The proportion of caregivers who providing 20 or more hours of care who have experienced a physical or mental health problem due to caregiving is nearly double that of those who provided 1 to 5 hours of care. And these differences are statistically significant as well. When we compare racial or ethnic groups, the proportion of Native Hawaiian or Pacific Islander caregivers who had experienced A physical or mental health problem from caregiving was at the highest at 21.4%. But this estimate is statistically unstable and requires pooling of previous CHIS years. In that case, we see that white caregivers reported the second highest proportion at 15.3%. CHIS 2020 data indicated that a majority of caregivers were employed. That's about 64.4% that were employed, but only a tiny fraction used employment-based benefits, using a temporary or vacation leave at 2.8%, or paid family leave at 0.7%. Now I'll turn it over to my colleague, Dr. Kathryn Kietzman, to talk about some of the public policies and recommendations that we have identified in order to mitigate the negative health outcomes we have identified in this policy brief.
Thank you, Sean. As Sean just mentioned, in addition to the hours that are spent caregiving, about 2/3 of California's family and friend caregivers are also employed. More than half are working full-time. An additional 9% are working part-time. California has been a leader in the implementation of policies to support family caregivers through their places of employment. Nearly 20 years ago, California was the first state in the nation to pass a paid family leave benefit, providing up to 8 weeks of paid leave in a calendar year. The current wage replacement rates for paid family leave are 60 to 70%, with higher replacement levels issued to low-income workers. The paid family leave benefit is paid for by employee contributions to the California State Disability Insurance Program. It provides partial wage replacement benefits to California workers who need to take time off from work to care for a seriously ill family member, or to bond with a new child, or to participate in a qualifying military event. The majority of paid family leave benefits in California are accessed through this public program. In 2018, only 3.4% of eligible employees in California were accessing paid family leave through private voluntary plans. Yet despite California's family leave being the largest source of financial support for working caregivers, we found that less than 1% of the caregivers in our study reported using this benefit. There are several factors that likely contribute to the very low uptake of paid family leave in California. The benefit provides wage replacement, but no job protection. It does not require employers to hold the caregiver's job until they return to work. For many, the level of income replacement is insufficient. Many people simply cannot afford to take time off at the current level. The 8 weeks of time off is not enough, especially for those who are engaged in intense caregiving roles, caring for family members or friends with high levels of ongoing need. For example, caring for a person with dementia or someone who has severe physical care needs and needs intensive hands-on care. The current eligible caregiver has to be caring for a seriously ill spouse or domestic partner, parent, parent-in-law, grandparent, child, grandchild, or sibling. This family definition excludes friends and other non-related caregivers who are also providing substantial amounts of assistance, and this effectively denies them from accessing this benefit. Other concerns related to low uptake include potential lack of awareness or knowledge about this benefit, and this may be exacerbated for people who are non-English speakers or have limited English proficiency, for immigrants with restricted access to information about benefits to which they are entitled, or that they may be hesitant to access due to public charge concerns, or the belief that the use of public benefits could interfere with their being legally gaining legal status in the United States, through being denied a green card or visa. There have been a number of enhancements to caregiver support policies in California. So I'd like to talk a little bit about some of the good news. Some of the recent policy actions in California really have the potential to increase the use of paid family leave, and also they introduce other opportunities to enhance supports for caregivers. So issued by executive order of Governor Newsom in 2019, California's 10-year master plan for aging has introduced a window of opportunity to advance a host of policies and programs that support the needs of our aging population and their caregivers. Since July 2020, the California Family Rights Act has required employers with 50 or more employees to grant caregivers up to 12 weeks of protected unpaid time off within a year. And as of January 1st of this year, the threshold for the California Family Rights Act has been lowered to employers with just 5 or more employees. And this has significantly expanded access to these job protections. The California Family Rights Act and the paid family leave benefit together combine the important wage replacement with essential job protections that caregivers need in order to really make use of these benefits. And this is all really, really good news. There are other supportive state-level policies for working caregivers that have recently been advanced or are currently under consideration. A bill by Assemblymember Gonzalez of San Diego sought to increase the income replacement for paid family leave to 90% of weekly wages, but this was vetoed by Governor Newsom. Other proposals are still in the mix, however, that could really help caregivers, including a bill that would broaden the definition of caregiver to include a person that's designated by the employee, and thereby making friends and other unrelated caregivers eligible to participate. Another proposal would increase the number of job protected and paid sick days from 3 to 5 days a year. This seems like it might be a small incremental change, but it can make a difference in the lives of caregivers to get that employment pay. Another bill would protect employees from discrimination resulting from their family responsibilities. And yet another would require the Employment Development Department, who issues the paid family leave, to update their language assistance programs to better serve limited or non-English speaking caregivers with their paid family leave claims. So we have some recommendations to improve the lives of caregivers. The abysmally low rates of paid family use in California suggest that in addition to enhancing the benefit, we really need to increase awareness of this program, improve access, and encourage uptake. It's especially important to promote paid family leave to those who are caring for someone with a serious illness, as they currently only represent about 14% of paid family leave program users. The vast majority of paid family leave benefits today are used for families bonding with a new child. And while employment-based benefits are a logical vehicle for advancing caregiving support policy, it's really important that we do not forget the family and friend caregivers who are not employed and or who do not qualify for employment-based benefits. We must also promote policies and programs that better support the physical and mental health needs of all caregivers. As our data shows, there's a significant proportion of family and friend caregivers who are suffering from physical and mental health problems that they ascribe to the caregiving responsibilities that they have assumed. Our data show that 1 in 4 California adults are providing care to a family member or friend with a serious illness or chronic illness or disability. Their interactions with the health and social service systems that they navigate when they're supporting care recipients' needs present a largely untapped opportunity for providers to also assess and address the unmet needs of caregivers. The state could require standardized and mandatory assessment of caregivers that's integrated into their visits with care recipients when they're visiting an array of service providers. And through this type of outreach and assessment, the needs of caregivers would also be identified. And ideally, they would be identified earlier when they can be connected to programs and supports to prevent or help offset their experiences of financial, physical, and or emotional distress. There are existing programs in California that I want to bring to your attention, and they provide a model for these types of supports that could be expanded, need to be expanded, and also could be replicated in different settings from where they're currently offered. So California's Caregiver Resource Centers provide one such example. They have a comprehensive set of support services, including specialized information and referrals for caregivers, family consultation and care planning, respite care to give a break from the caregiving responsibilities, short-term counseling and support groups, professional training, legal consultation, and educational seminars, webinars like this, where caregivers can get information on topics such as dementia care and so forth. The federally funded VA program, Veterans Administration Program of Comprehensive Assistance for Family Caregivers, provides another example of a model caregiver program. It provides supports for family caregivers of post 9/11 veterans, and it addresses both caregiver and care recipient needs. This is really such an important approach when explicitly the recognition of the reciprocity between caregivers and the people that they care for are acknowledged and are addressed under the umbrella of one program, such as what's offered here. The services and benefits that the VA offers through this program include a living wage, respite care for at least 30 days a year, mental health services, health insurance coverage, caregiver training, support, caregiver support line, caregiver support coordinator. Providing care often involves a high level of coordination to help your care recipient access services and programs they need. So there are a number of important inroads that these programs have made to date. But we know that there are so many more caregivers out there that are not connected to these services. And we hope that these data will help to raise the bar on attention to these issues. Whether programs are providing financial, physical, mental, or social support, it is really critically important that we find more ways to care for the caregiver. And as Sean reminded us earlier, by sharing the words of Rosalind Carter, in the course of our lifetimes, we will all be caregivers and we will all need caregivers at some point. It's essential that we implement policies and programs today that will address caregivers' needs today, tomorrow, and well into the future. Really thank you for joining us today, and we'd like to now open it up for questions from the audience.
Thank you, Kathryn and Sean. Good afternoon, everyone. My name is Tiffany Lopes, and I'm the Director of Communications here at the UCLA Center for Health Policy Research. I will be going through the audience questions today. I encourage you, if you haven't already, to use the Q&A function in Zoom to ask questions. So let's get started with the first set of questions. We have some questions about the survey and respondents, some sort of technical questions. Can you talk about how the survey was administered and how respondents were identified?
The caregiver module was part of the California Health Interview Survey, which is an ongoing statewide population level survey in California. It is address-based sampling. The survey is administered both by web and by phone. And so in 2019 and 2020, there was a specific module that asked questions about people who identified as being caregivers using the definition that Sean shared with you earlier. So that's how they got into the survey. That's where we got the information. So these are generalizable data representative of our state's population and just part of a larger health survey. The advantage of having the module within the larger health survey is we're able to connect the information about the caregivers with a lot of the demographic information that Sean also shared earlier to see how they are faring as they weather through their caregiving responsibilities.
This person says, I'm interested to know if younger caregivers, particularly those in their teens and 20s, were included in the survey. From my understanding, younger caregivers are a growing demographic. Does any of the data survey those who are 20 years and younger?
So in our survey, we included adults, and so in our sample, we only include adults, so starting at 18 years old and over. And so I don't think we have the teen caregivers, but that is a very interesting and increasing demographic that we're also interested in looking at.
Yeah, and I think that to also respond to the question, there is growing attention to the concerns about younger caregivers. So one thing we are able to do with our data is look at segments of age groups starting at that 18, that's our low level, but we're able to look at caregivers who are 18 to 25, for example. One of the interesting findings that I don't think is presented here, but it's in our brief, is younger caregivers actually experienced higher levels of financial stress. The caregivers who were between the ages of, I'm looking at my data here, 18 and 44 actually. It was a larger group than 18 to 26. But when you look at that group, they're experiencing higher levels of physical and mental health problems than our older caregivers. And I thought this is a very interesting finding. It gave me pause to think about, well, why would the younger caregivers be experiencing more physical and mental health problems? Arguably, I think the caregivers that fall in this group may be juggling multiple responsibilities. Perhaps older caregivers have gone through some of the life stages where they're fully engaged at work, fully engaged in raising their own children. So I think that might partially account for that finding. Other thoughts are that as people are getting older, mental and physical health problems, they may attribute it more to themselves and not necessarily attribute it to the caregiving responsibility that they have. Thank you for raising that question about younger caregivers, because they are a really important increasing demographic.
Thank you for that thorough answer. Why were parents or primary caregivers of children not included? Many of their challenges are the same, especially mothers caring for a newborn/infant.
Actually, I think the previous question was asking about the age of the caregivers. We do have information about caregivers who are caring for people across the life course. So our sample is not restricted to caregivers caring for older adults. It's a very small percentage in our data. I think it's about 3% of the caregivers reported they were caring for a seriously ill or disabled child, less than 18 years of age. So we do have that. And just in general, with all of the findings we're presenting today, I just want to make the point, these are sort of high-level estimates, initial point estimates from the caregiver module in the CHIS survey. We haven't done extensive analyses that we definitely plan to do with these data. They're very rich, and we have 2 years of data to merge and to dig deeper into a number of issues related to different age groups, gender differences, et cetera.
What kinds of mental health outcomes were measured? Could it further be specified as probably anxiety/depression, or more broadly as adverse mental health symptoms, or both?
I would say it could be broadly defined as both, because the question that we did ask was very specific in terms of if they have suffered or experienced a physical or mental health problem during the past year, and if that physical or mental health problem was due to caregiving. So it was a very specific question.
Right, and I think, again, we have measures elsewhere in the California Health Interview Survey where we will look at the relationship between a more specific measure of depression and anxiety. We have a measure, the Kessler-6 measure, which looks at psychological distress. But our question in the caregiver module, as Sean described it, was much broader about physical mental health problems due to caregiving.
Yeah, and we also have other questions such as loneliness that is very rich right now in terms of analyzing and exploring and how that affects caregiver population. And that's something we're looking forward to doing in the future as well.
Respite care is desperately needed by family caregivers. Do you have data or policy information addressing this critical issue?
We don't have immediately data on that issue. I think that has been an issue for many, many decades, the lack of respite cares. The programs that I mentioned, the VA program and the Caregiver Resource Centers both provide respite care. But in terms of really addressing the need, I think that their capacity is probably limited in how much respite care they can provide relative to what the demand really is for an ideal respite program. So it's a very important piece of support for family caregivers. Absolutely, respite care. So thanks for asking about that.
Based on your research on caregivers, can you offer any insight on the need to have a universal LTC insurance program in California? What model would you recommend, if any?
Can you repeat the very first part of that question, Tiffany?
Can you offer an insight on the need to have a universal LTC insurance program in California?
And then where caregivers fit in it?
And then what model would you recommend?
A universal one.
Good answer.
I love that. Yeah, I don't have a recommendation about a specific model. I think there are people who are dreaming up those types of models for care on both sides. I mean, the long-term care for the recipient. I would hope that such models would incorporate similar supports for caregivers. Again, addressing both needs is, I think, a robust way to really move the needle on improving health outcomes for both members of the care dyad.
You also have data about, oops, lost the question here, about behavioral health problems, for example, increased alcohol/recreational drug use.
We do have questions in the California Health Interview Survey regarding substance use, but we did not run that in terms of the caregiver population, but that is also a very interesting set of analysis that we could be doing in the future.
There seems to be a lot of focus on the financial impact of caregiving, but there seems to be less focus on physical and mental health. The data seems to support the need to provide this type of support. Do you think public policy will effectively address mental and physical health?
I think that's a $64 million question, the last part. I mean, we could talk about whether for the general population, there's that support at this point for people with mental health, specific mental health concerns. So I do think we have a long way to go to effectively respond to the mental health needs of caregivers. I don't think we're doing a sufficient job. I think that there are certainly model programs to point to. There are efforts underway, but in terms of addressing the larger needs. So we did focus somewhat on financial, perhaps more. And part of the reason I think for that is pointing to the policies that are in play, which are related to employment and financial matters. But the mental and physical health issues of caregivers have been well documented. That people who provide caregiving are at higher risk for a number of negative health outcomes, and to the previous question about health behaviors, for higher risk for engaging in negative health behaviors that impact their health.
How long has the caregiver module been part of CHIS, and will it be ongoing? Is it being expanded?
Well, this is the first time we had a caregiver module since 2009. And so we're very excited to have had the support of Archstone Foundation to provide these caregiver questions again for 2019 and 2020. I think that, I talked about the master plan for aging that the state is engaged in. There's a lot of effort underway for the aging population and the caregivers to document, to use data to document where, the state of the union now with, for people with caregiving needs and for the caregivers who provide that care. And so I think that there's momentum and an opportunity right now that I would hope that we'll get to see a repeat of this caregiver module in the years ahead, because I do think it's, I'm biased, of course, but I do think it's really valuable. And certainly there's a host of folks who've been advocating to improve care for older adults in the state who I think agree. And hopefully many of them are on this call too.
Is there any data specific for caregivers caring for adults with individual and intellectual disabilities, or any plan for that?
We do, in terms of the CHIS data, have questions in terms of what kind of disability or illness specific care recipients provide, but I can't recall on top of my head if we had intellectual disability as part of those questions.
There are many adults who live alone and have no family or friends to care for them. They cannot afford to pay for the amount of care they need and do not qualify for IHSS. Are there any plans in the state of California to address care needs for those needing help but are falling through the cracks?
Again, I would point to the master plan for aging, where these types of deficits in care are high on the list of what the state is interested in addressing, identifying and addressing. This is a concern as our aging population continues to grow, and we don't have the sufficient professional or paraprofessional workforce to care for folks, and to the point of lower income adults who don't qualify for IHSS. It's that group that sort of falls in between. There's just no way to pay for it out of pocket for most people who, and for those who qualify for IHSS, there are issues there with getting, again, with workforce issues, just being able to get caregivers on board who are able to meet individuals' needs. So I think we have a lot of work to do in this arena.
Definitely. There seems to be a lot of questions about the increasing younger demographic. Can you share more about that? Has it been over the last 10 years that there's been this growth? And who are the younger generations caring for? Is it their parents, their grandparents, children, perhaps?
I don't think we have sufficient data from our caregiver module in CHIS to speak to that, at least at this point. Again, we are going to be doing some additional analyses, but I know that there are others who have looked at this issue. There have been some very important reports published on this issue, which have that kind of information. I don't have the reference at the top of my head, but certainly we could gather that report and share that for those who would like to get that more information.
And for family and friend caregivers that we did identify in our survey, in the appendix of the policy brief, we do have a breakdown of who, in terms of family relationships, who the caregiver provided care to. So that's also another resource that you can look at.
We have some questions about a couple of the slides. One is for the chart showing increased financial stress as number of care hours increase. What severity of financial stress was that?
Yeah, so those on the infographic is the severity is somewhat or extremely. So it's the combination of both levels.
Slide 11, does it say that the majority providing care for those who did not live with them?
Yes.
Thanks. Quick answers.
Yeah. So yeah, the for slide 11, it is a majority of caregivers had provided care to care recipients who did not live with them.
The number of Americans 65 and older will more than double over the next 40 years. President Biden's Build Back Better plan is supposed to expand healthcare coverage and Medicaid coverage for home care services for older adults and people with disabilities. Can you talk about what this means for caregiving and families?
Can you repeat the question?
Sure. President Biden's Build Back Better plan is supposed to expand healthcare coverage and Medicaid coverage for home care services for older adults and people with disabilities. Can you talk about what this means for caregiving and families, and just maybe describe a little bit about that aspect of the Build Back Better plan?
Yeah, I think we do have another slide for it, but it's more related to paid family leave. I'm not too sure about increase healthcare coverage in terms of the impact for caregivers without having to really look at data or the specifics of that bill. But in terms of the Build Back Better plan that's been talked about, we do have more additional information about that just in terms of paid leave. And so in terms of the Build Back Better Act or Build Back Better plan, it is, it passed through the House in terms of, and it's now being discussed in the Senate. And this would create a program to provide basically universal paid leave up to 4 weeks for private sector workers. And it would largely take effect in 2024. And that's basically the House version of of the bill. And this is very exciting just because we talk a lot about California and what, California being a leader in paid family leave, but this actually also sets a tone in terms of what, the need for paid family leave, given that the United States is probably the only developed or industrialized nation that doesn't have a national paid family leave program in place. And so you can see on the slide some of the specifics of the Build Back Better Act. But a word of caution is that given that this is the House version of the bill, things can move and a lot is still at play. So, a lot of these details might change in the future.
I would just add that in terms of the Build Back Better Act, which I have to say slowly.
Yeah.
I think it really marks, and if it passes, when it passes, it really marks an incredible investment in home and community-based services that would benefit the people we're talking about, the caregivers, the people they're caring for. It would set a precedent and provide some attached with some real resources attached, which could significantly shift our efforts to improve services for people with disabilities, older adults, and the people that are helping them. So I do think that there's great promise there. In addition to the specific area we focused on, the paid family leave piece, there's a lot more in that plan that would really help us move the needle forward as we need to in this area.
Individuals of some cultures and backgrounds, caretaking, especially of parents as they get older, is seen as an inevitable responsibility. Are there community organizations or other agencies that can provide resources or support to these diverse communities with diverse needs and cultural beliefs?
Yeah, absolutely. I think they're amazing local community organizations that are very responsive to the people they serve. One program that stands out, which those who've been around this topic for a while, adult day healthcare, but more recently now called community-based adult services. These centers are often designed to respond to specific cultural groups in language, in the food that's provided, in the approach, in the staffing, and so forth. So I think that, again, California, with all of the diversity that we have, we do have great examples of programs like Adult Day Healthcare, or CVAS, that can be very much more focused and targeted on these cultural, linguistic needs. And that's going to continue as our older adult population continues to become more diverse as we move forward. So we need to build and replicate more and more programs that infiltrate that approach into other community organizations that are set up to respond to long-term care needs of our population.
It sounds like a lot of folks have questions about different resources. So this person says, what further outreach can be done to ensure that caretakers can get their hands on resources or information to get the financial or mental health support they need? I do encourage, if there are any organizations attending, if they want to post their information in the chat as well. I see some folks have started to do that, but we encourage you to definitely share your resources.
Yeah, I can also give one starting point in answer to that question. Aging and disability resource centers have been around for quite some time. I think that there's more recent efforts to build those out, and they're supposed to be one-stop shops for folks to go and get information about caregiving needs, whether it's for the caregiver, for the care recipient, really addressing the whole family set of needs. So those are available in California. Certainly the area agencies on aging are set up to, most of them contract with local community providers that provide resources for caregivers and care recipients. So these are all places where caregivers can go and start to get questions answered, to find the services. It's a very complex system, fragmented system, which sounds sort of contradictory, in order to navigate and know what programs the care recipient qualifies for. They vary by age. They're funded through different mechanisms. So having a one-stop shop like an Aging and Disability Resource Center or an area agency on aging can be a good starting point to at least get people on the path to find the resources that they need that will help support them and the person that they are caring for.
Are California Caregivers Resource Centers new? Where are they located? This person said that they've not heard of them, so this is good.
Yeah, we're getting some word out.
Yeah.
Caregiver Resource Centers have been around for quite some time. I had the good fortune to actually do an internship at the Family Caregiver Alliance, and that's the genesis. That's the organization from which these caregiver resources have been developed. They are available statewide in Los Angeles. It currently sits at the USC, our friendly university across town, and they have a caregiver resource center, but they are available in different locations throughout the state. In the recession 2008-9, they took a terrible cut to their budget, and so I know that their programming had been reduced at that time, but I think they've been building back up over those years. But they've been around. I think Family Caregiver Alliance goes back to late 70s, early 80s. So they've been around. I think their focus was initially focused very heavily on people caregiving for people with dementia and other cognitive impairments, but they've expanded over the years and really serve a broad range of caregivers. Wonderful organization.
This person says, I was not aware of the paid family leave in California. I only knew about the unpaid leave. Thank you. HR staff may not be aware or helpful. What will it take to work with HR to get this type of leave?
Yeah, I mean, that's certainly a concern. And when we looked at this data and said, well, what's going on here? You know, I made the point that this is also a benefit that's taken up more by families bonding with a new child, which is wonderful and important and needed. But there's a very small percentage of people who are caring for someone with illness or disability who are accessing this benefit. And I think I tried to enumerate some of the reasons why that might be. But communication and, this is where employers really need to, in my view, take a lead. This is a benefit that's paid for by workers. We're paying into this. If we're paying into state disability insurance, we're paying into this benefit. So it's a responsibility of employers to make sure that their employees know that this exists. But I would say that a partner from government wouldn't hurt to also invest in getting this out. Public health community could also be a messenger to get this out, because it's a public health issue. Caregiving is a public health issue affecting us. So those are some thoughts about that.
Absolutely, thank you. I apologize if I have asked this already. There are a lot of questions that are coming in the chat and Q&A, but what percentage of respondents were family/relative caregivers versus non-relatives?
Yeah, so in our in just data, we found that 13.4%, if I'm not mistaken, were non-relative care recipients, and so and then the rest were family, immediate family, and also relatives.
Yeah.
I would add that the 13.4% includes individuals who are considered friends as well.
Do you have any data on non-relative community care providers who are IHSS and HCBS providers to non-relative recipients?
Data in the, I'm not sure what kind of data does it, can you repeat the question? Sorry.
What research data do you have on non-relative community care providers who are IHSS and HCBS providers to non-relative recipients?
Okay. Yeah, there have been a lot of studies done on IHSS workers. We do know in California that the vast majority are family members. It's a consumer-directed program and the largest one in the country. So the ones who are not related, I think the question is raising, an interesting point. the value of the IHSS program is people can choose who they want to provide care. That may not always be your family member, even though even though majority are in California. It may be a friend or a neighbor, but I don't have a research, this study, we didn't look at that group, but there have been other studies about IHS workers that might unpack that a little bit more. But it's an important program and another source of support for family and friend caregivers.
We have time for a couple more questions. So this person says, family leave doesn't seem like the best policy response to need for time for caregiving. It only applies to employees, which self-employed and retired or not. And it's based on assumption of episodic care, which care of chronically ill is not. Is there another policy category to recognize that volunteer caregiving underwrites long-term care in the US?
That's a great question. And I agree that we pointed to paid family leave as an employment-based policy, but there are a host, many who are not in that role of employment to be able to access that benefit. I think that we're well behind in other policies that are not connected through, and maybe that's part of the reason for that is because it is employee financed. So I think we have to get public attention raised to the issue of caregiving and how it affects all of us, and that public dollars are needed to lend supports to caregivers, because you have to recognize that, as Sean pointed out earlier, the contribution that informal unpaid caregivers are making in our state, in our country, are incredible. And most of them are doing it because they care for the person. That's what they want to do, and it's what they feel that they need to do. But that doesn't take out of the equation the fact that it's actually saving our health and social care service delivery systems lots and lots of money, that people are stepping up and continuing to do this. So anything that we can do from a public policy point of view to find ways to better support our volunteer family and formal friend caregivers, I think is, it's really something that needs to happen at a much higher level than it's happened to date.
Person says, my mother recently passed away and I've had to take over my IDD sister's care full-time. I am her caregiver and being paid for only 4 hours. I recently completed my MPH, but now I am unable to work full-time due to my sister's needs for full-time care. Will caregiving be considered a public service that would qualify for school loan forgiveness?
I think that's a great policy idea right there. So thank
Absolutely.
you for sharing that. Thank you for sharing your situation. I'm sorry for your loss. And one thing that our data doesn't show is where we look specifically at caregivers who are caring for one person, but I would like to say that we have to bring attention to the fact that that's often not the case. Often caregivers are caring for multiple people at the same time. They're caring for somebody with a disability. They also have children that they're raising and so forth. So I do think that some connection between the value that's being extended to society by the role that voluntary caregivers are providing could be translated into a public benefit that could be that offsets or rewards that by supporting education and other career pursuits. So thank you for raising that. It's a great idea.
One last question. Where does the research go from here, and how can we help get the word out and create change?
Great big question. Where do we go from here, Sean?
I mean, there's been a lot of talk about, especially in our presentation right now, about diving deeper into the physical and mental health aspects of caregivers, as well as younger caregivers, and I think those are, from our perspective, we have data from the 2019 California Health Interview Survey. So combining that with the 2020 gives us a better opportunity to really hone in on some of the more granular issues affecting caregivers. But in terms of how people can help in terms of identifying and promoting awareness about the issues of caregivers. We have this webinar, but it doesn't stop here. And we have, I think, multiple community organizations on our webinar right now that can point towards more of the direction of advocacy, as well as raising awareness for caregivers.
And I would also add that we're already working with the state to provide some of our data estimates from this caregiver module to the data dashboard on aging, which is really measuring the progress of the master plan for aging over the next 10 years. And that also kind of bounces back to someone's earlier question about continued data. I think we need to what you can do to help is, first of all, you're helping us by being here today and listening and asking questions and raising all of the issues that you're raising. That will help us shape what we look at next in the data, among other things. But to the extent that you are in a position to share this information to others, to those in your communities, to decision makers, this needs to be a movement. And the Master Plan for Aging is a vehicle that I think has great promise for moving these issues forward in a way that they just haven't been able to. They've been sort of intractable for a number of years. We make a little progress and then we sit back, but I think things are a little different right now. So I'm hopeful, and I really appreciate all of the input from today's audience, and look forward to presenting some more advanced analyses in a future format. We have yet to be determined, right?
Yeah.
And thank you both for all of this work. There's so many questions that are still coming in. I wish we had an extra hour to just keep going, but unfortunately, that's all the time we have for today. I just wanted to thank you all for attending this month's webinar on caregiving. We will be posting the recording to YouTube in the coming weeks with closed captions. You can visit healthpolicy.ucla.edu/seminars for that. If you'd like a copy of today's presentation, please email us at healthpolicy@ucla.edu. And just a reminder that the CHIS data user training will be held on Thursday, December 9th. So you can register for that. Thank you and have a wonderful rest of the day.
Thank you, everybody.
Thank you.